Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. I'm an expert psychopharmacologist, and I specialize in the maintenance of psychotropic medication regimens. I've helped thousands of people navigate psychotropic medication trials, and I've developed a curriculum that focuses on how to do that successfully, how to forge a successful therapeutic relationship with your provider, and how to avoid the common early pitfalls. Today, I'm going to give you a quick overview of how mental health treatment can go astray, just in terms of designating what it is we're going to be treating, which in psychiatry requires a little extra effort on the part of the clinician. Let me repeat that. In psychiatry, it's not always obvious what we need to treat. Patients are sometimes confused and look to their providers for answers as to what's going on with them, but even patients who understand what their symptoms are a lot of times can't see all of their symptoms. Patients have a blind spot for themselves. We all have a blind spot for ourselves. And so a good practitioner in making a comprehensive evaluation a lot of times will elucidate symptoms the patient didn't realize that they were experiencing. And even patients who have a lot of insight and who are well informed about what's going on with them may not have a very explicit idea of what target symptoms it is that they need treated. Today, I'm going to focus on 3 elements of the treatment plan: identifying target symptoms, defining terms and using proper terminology and syncing that terminology between patient and provider, and defining and measuring improvement. What do we treat when we treat any medical condition? It seems so obvious and straightforward, the concept of treating symptoms, right? What else are we going to treat? If we adopt a target symptom-based approach, how can things go wrong? Even if we don't know the diagnosis. I've talked about this in other videos. Most diagnoses in psychiatry are syndromes anyway, meaning we don't know the exact etiology, the cause, nor the exact pathophysiology, the exact disease process, what's going wrong in the central nervous system. In patients with major depression, say, such that MDD, major depressive disorder, is not a single disease. It really should be called major depressive syndrome, because it's not one disorder. It's a group of conditions with different causes and disease processes, most of which are unknown, that all happen to meet diagnostic criteria for major depression, according to the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, which is published by the American Psychiatric Association. It is the diagnostic Bible of the psychiatric profession. But MDD is not a single illness. Not everybody with major depressive disorder has the same disorder. And so how does that affect treatment? Well, it doesn't. If we don't have a specific cause, if we don't know that a depression is being caused by a thyroid hormone deficiency, for example, in which case obviously we would replenish the missing levothyroxine, then we can only treat symptoms. But we can do so very effectively. If a person is experiencing crying spells and the tearfulness is excessive and they don't feel any better afterwards, which is what crying is supposed to accomplish, then by increasing levels of the neurotransmitter serotonin, we can block that tearfulness, stop it in its tracks physiologically by increasing the physical threshold for tears. The need, the veritable ability to shed tears is governed by a physical threshold above which crying is impossible. We can make it impossible to cry if we want. The patient might not feel any better, but we can target tearfulness as a separate physical phenomenon. Even in response to grief, even if somebody died, we can deny the mourner tears. That would be the wrong thing to do. That's counter-therapeutic, in my opinion. If a person is grieving, they need to cry. But it really depends on how excessive it is and how distressing it is to the patient. Often, patients who take selective serotonin reuptake inhibitors for another reason will notice their blunted ability to cry, and they might even complain about it. They notice that they're no longer crying at movies and weddings, and it can be disconcerting. I think most people want to be able to cry. Not all tears are pathological, obviously. There are bittersweet tears and there are tears of joy, And the threshold is identical. We block tearful sorrow, we block tearful joy. And obviously that's not a good thing. Tearfulness is part of being human. That's why we have to define our symptoms, our target symptoms, and the provider and the patient have to dialogue about what needs to be fixed and what we need to leave alone, what we can just watch, and what can be improved by sleeping better and exercising, everything. What's a symptom to one person is not necessarily a symptom to another, just like what's a side effect for one patient is not necessarily a side effect for the next. Weight gain is not always unwelcome. Lowering the sex drive is not always a problem. It depends. It depends upon a person's demographics and given circumstances. We have to tailor the treatment to the individual, but tearfulness is a good example about how it's not always straightforward. Wrong assumptions can be made. And so it's imperative that the target symptoms be explicitly defined and reviewed at every visit. Some people with OCD don't necessarily want their punctuality or their organizational skills or perfectionism diminished in any way. Some rituals are comforting and not inherently unhealthy. Even the DSM says that in order for it to be a symptom that is part of a disease process, an illness, there has to be academic, occupational, or social dysfunction, trouble at school, work, or between friends and family, and or subjective distress. It bothers the individual. One or the other or both. A lot of people with anxiety enjoy a little sense of urgency, believe it or not. I've been told that by many a patient with anxiety. They say that it helps them get things done and they don't want to be complacent. My opinion, it's familiar to them and they have anxiety about not having enough anxiety. It's irrational, but that is the nature of anxiety. It doesn't want to be treated. I've had many conversations with patients about that. So to each his own, and we have to dialogue about this in order to make those determinations. There also has to be a discussion to prioritize this list of target symptoms. It's not enough just to say, okay, here's what we have to fix. Which ones are we going to manage first? Because sometimes we have to defer treating one condition, ADD for example, until we get another, anxiety say, under control. Because sometimes the treatment for one set of symptoms exacerbates another condition. Severe clinical anxiety always trumps attention deficit disorder because it's more important. It's more disruptive to a person's life, usually. But also because stimulants like Adderall can cause a panic attack. So we have to treat the anxiety first. We have to stabilize that symptom, get it as good as we can, and understand how the patient is going to respond to a given medication or medication regimen. And then we can risk destabilizing that and understanding what the stimulant is doing. So we can't just make assumptions about what needs to be treated and how we're going to go about early treatment. And it's a huge mistake in psychiatry to determine a diagnosis and then just select medications that are used to treat that diagnosis. Because for one thing, the diagnosis could be wrong. That happens. I've actually seen patients erroneously diagnosed with bipolar disorder, which happens all the time, and then treated with mood stabilizers when they don't need mood stabilizers. The patient's not experiencing mania. Their mood is unstable, sure, but their mood swings are something else. And the medications that are being chosen aren't going to help their actual symptoms. That only happens in psychiatry, folks. In other specialties, we can just order a blood test or take an x-ray or perform a biopsy to determine the diagnosis definitively, to figure out what's going wrong with the body and then to intervene with medication or some other physical treatments to fix it. Whereas in psychiatry, we're usually deriving the diagnosis. And at best, usually, it's a diagnostic paradigm. We're deriving a paradigm. It's syndromal. And so there's a very real danger of giving a medication that's not indicated at all by not adopting a target symptom-based approach. Other specialties tend to honor the diagnosis more because a definitive diagnosis allows us to treat the cause and also might allow for a definitive cure. So in that case, you wouldn't want to solely focus on symptoms. But psychiatry is different. We may never know the cause. We may never know what's fundamentally going wrong so that we can treat that. The best we can do a lot of times with these syndromes is just treat the symptoms that have materialized. So that's number one. Elucidate the symptoms, the target symptoms, bring them to light, prioritize them, and treat those. But there are additional pitfalls. There are other ways in which things can go wrong in psychiatry, even when the practitioner and the patient are focusing on symptoms. Because there are other erroneous assumptions that practitioners often make, especially inexperienced ones. I have a whole premium content video series on this. Please check for a link in the description below. Often, doctors and patients aren't even speaking the same language. Insidiously enough, very simple terms like panic and mania and racing thoughts have various meanings to different patients precisely because those terms are also colloquial. That's why we don't make official diagnoses of drug addiction or drug dependency anymore, because there was confusion, ambiguity caused by the fact that laypersons were using those phrases colloquially. Because words and phrases that also occur in the vernacular are not operationally defined. They mean what they mean in various contexts, and that changes from setting to setting and from person to person. If you're in London and you try to buy a cookie, they'll know what you mean, but they'll sell you a biscuit. But if you don't know any better and your British doctor tells you to eat more apples and less biscuits, then you might go home and start skipping breakfast, but go right on eating Oreos right out of the package. The doctor and the patient have to be speaking the same language, and often they're not, and they don't even know it because assumptions are being made. The astute clinician will stop a patient who's talking about a quote-unquote panic attack and ask for specific symptoms. When I evaluate a patient for panic, I want to hear about shortness of breath, chest pain, trembling. I want to hear about feeling overwhelmed, an urge to flee, a fear of having a heart attack and dying, a fear of being scrutinized socially and adversely judged. Before we get into details about the settings and the triggers and the timing and the frequency, before we start collecting details about how often a person has a panic attack, we have to be sure we're on the same page as far as what the patient is calling a panic attack. Moreover, how can we define and measure improvement if we don't know exactly what we mean by terms like mania, another word patients frequently misuse that gets us into a lot of trouble? That's how patients end up on mood stabilizers they don't need. When a patient tells me they were manic, I immediately want them to stop and describe it to me. Break it down so we know the exact target symptoms and so that I can verify that it is, in fact, mania. Insomnia, expansiveness, grandiosity, profligacy, hypersexuality, racing thoughts. That's another one, another extremely common misnomer. Racing thoughts is a manic symptom. It's a consequence of a formal thought disorder in which the speed of one's thoughts is excessive. The form of thought, the connection between ideas and the manner in which words and phrases are being used as opposed to thought content. The patient has so many thoughts coming to mind at once that there's a subjective sense that they can't talk fast enough to get them out. They're tumbling around in the mind and usually they just come tumbling out of the mouth. And we do see pressured speech and flight of ideas on the mental status exam. But that's not what patients mean when they say racing thoughts. What patients mean when they say racing thoughts is anxiety. 10 times out of 10, when a patient tells me that they're having, quote, racing thoughts, what they mean is that they have a lot of concerns and they can't shut their mind off at night. It's usually a complaint of insomnia and anxiety, and it's virtually never actual racing thoughts. Because the patient who's actually experiencing racing thoughts wouldn't complain of it. They would more likely complain of that subjective sense of having too many ideas at once, and moreover, they would demonstrate their racing thoughts by talking fast and being difficult to interrupt and going off on tangents. But terms like panic attack and mania, they're thrown around all the time by patients, and doctors don't stop them and say, wait, what do you mean? They just take them at face value. Oh yeah, we all know what a panic attack is. We all know what mania is. It's not medicalese, and it's a mistake. Other terms I urge patients and providers to expressly define include feeling tired. That's a very common complaint. Patients will tell me that all the time. When I ask them about side effects, they'll come back and say, I'm doing better, but I'm just feeling tired. But do they mean sleepiness, oversleeping, or taking unwanted naps? Or do they mean feeling lethargic, i.e. having no energy. And when patients say, I have no energy, do they mean purely physically, like feeling weak and tired when they try to exercise, feeling drained before they've begun? Or is there also a lack of motivation, trouble getting to the gym in the first place, procrastination, not getting things done? These different symptoms can mean very different things. They often co-occur, but some imply a low mood more than others. And it's important to make those distinctions. Dizziness. Does that mean lightheaded? Like you might faint, like you stood up too fast and you feel like you might faint? Or is the room spinning, which is called vertigo? One might mean you're dehydrated, the other is probably an inner ear problem. Upset stomach. Upset stomach tells me nothing. Is it acid burning? Or is there nausea, the urge to empty your stomach? You want to vomit. Sometimes patients say that, and the symptom they're talking about is diarrhea, which has nothing to do with the stomach. It's mostly the colon, way on the other end. All manner of GI upset could be comprised by upset stomach, including constipation, abdominal cramps, and bloating, none of which involve the stomach. There are also many different types of headache, so it's always important to know where it is, the distribution. Is it diffuse? Is it band-like a vice on the temples? Is it on one side of the head and then migrates? Does it throb? How severe is it? Are there associated symptoms? Is there sinus pressure? Is there a pattern? If your doctor doesn't ask you for details when you complain of frequent headaches, that's a bad sign. Even if we think they're probably a side effect of a medication, in which case they would be relatively mild depending on the dose, bilateral, diffuse, and they would come on 10 to 20 minutes after dosing. We would see that pattern. But without those questions, how do we know? Sexual dysfunction should also be described in detail. Providers should ask. Providers out there, ask your patients when they come back to you, because some patients won't bring it up. No pun intended. And feelings of embarrassment should be discouraged. I recently did a video on what questions you should ask your psychiatrist, and I compiled a list of over 60 questions plus additional follow-up questions that every consumer of mental health care should reference. You can get a free digital download of the complete list in PDF by commenting, "Give me the list," below. The download also contains a few tips for the patient on how to approach each visit, and one of them is to compile a list of target symptoms for your practitioner and to then expand and refine and order that list by asking questions that further elucidate your condition. To let the provider-patient dialogue inform that list, and to then maintain and reference it throughout treatment as symptoms get crossed off and perhaps new symptoms or more likely side effects are added. It's a good way to make sure that you're on the same page and that treatment stays on track, that your problem list matches the one in your medical record. One of the recommended questions, question number 48, is designed to make sure that the doctor and the patient are in agreement about the symptom list and to determine whether each symptom is being addressed in terms of the medication regimen. For example, mood symptoms versus physical symptoms versus behavioral symptoms versus cognitive symptoms. Sometimes practitioners will overlook cognitive symptoms because they're so focused on treating the mood or curtailing certain behaviors. A lot of times, patients don't complain of cognitive dysfunction, which is very common in mood disorders, because it's relatively mild and they don't even know they're having it. The clinician really has to investigate, has to ask those questions and perform serial mental status exams. Again, patients may not know all of the symptoms they're experiencing. The best that you can do is take that list in and say, okay, here's what I know I'm having. And then as you are diagnosed and examined, that list hopefully doesn't grow too much, but at least it's comprehensive. And then it needs to be maintained and it needs to be referred to at every visit. One symptom can certainly distract from another. The more severe and obvious symptoms can entirely eclipse the more subtle but no less clinically relevant ones. It's just not as straightforward as peptic ulcer disease, where you can stick a camera down someone's esophagus and look and see, or a torn rotator cuff, or even diabetes or hypertension, where all you really need is a blood test or you get a machine and tells you exactly what it is. In psychiatry, the symptoms can be elusive and esoteric, especially anxiety. Anxiety masquerades, it hides, it presents as other things, usually physical symptoms. And then how do you measure it? The final task which is to define improvement and to determine how we're going to measure that improvement, given that so many of the symptoms are subjective, can be quite challenging. Some are obvious. Drying the tears, stopping the panic attacks. Patients will know when they've stopped having panic attacks, believe me. Getting enough sleep, eating more, and gaining weight. Some actually have units like hours and pounds that make measuring easy. There are really advanced devices now on the market that one can wear to bed that yield a truly impressive amount of data. But other things are harder to quantify. And this is important because of the danger of settling for partial remission. A lot of times patients are greatly improved and they have no further complaints. They're happy and the clinician is satisfied, but in fact, they're still experiencing clinically significant levels of anxiety or residual depression or whatnot, and they're simply not feeling the best that they could be, as they should be, nor are they functioning at top capacity, even if they're back at work. Another one of the questions in my list, question 43, is how will improvement be gauged? These are questions for the provider that you should ask your providers. How is improvement going to be defined and measured, and how will we know when my condition is in complete remission? Getting stuck in partial remission is a real and very common pitfall. And while neither the clinician nor the patient even know at the time, and everybody's satisfied, the relapse risk is significantly higher. That's why it's important. We would no more partially treat major depression than we would a bad infection. You have to take the right medicine at the right dosage for an adequate period of time, sometimes a few months, sometimes a few years. So that's a quick overview of how treatment can go astray, some of the top categories, just in terms of designating what it is we're going to be treating, which in psychiatry requires a little extra effort on the part of the clinician. Astute patients, though, can make sure that their clinicians are following through. Armed with this information, this knowledge, then you can help your clinician meet them more than halfway, as I often say. Please check out my online academy, notonanemptymind.thinkific.com, where you'll see all of this material in its entirety and my best premium content. As always, questions and comments are welcome.